All right, let's start. Okay, a very good. Well, we have a lot of participants from all around the world. I don't know what time that we should address right now. In fact, it's a good morning, Steve. I think it's morning in America right now, and a very good afternoon to Bravo in Europe. And for most of us in this part of the world, is about 9 p.m. in Southeast Asia. All right. So thank you very much, Bravo, for taking the time off for today and make his presentation. And also Steve, it's his holiday and he's also taking time off. And last but not least, Dr. Krisada from Thailand is taking time to moderate this session. So maybe let me start the session by briefly introduce Dr. Krisada, being the moderator for this session. Dr. Krisada Koviwibu is a leading facial plastic surgeon in King Chulalongkorn Memorial Hospital and Chulalongkorn University of Thailand. He's Thailand's first double board certified surgeon in facial plastic and reconstructive surgery with credentials from both the IBC FPRS and Thai board, a member of international organizations like EA, FPS, AA, FPRS, and AAO HNS. Dr. Koviwibu has trained globally, including observationship in UC Davis and the New York Head and Neck Institute. He is dedicated to advancing facial aesthetic and reconstructive care with expertise and compassion. Okay, let me pass on the stage to Krisada, and he can introduce Bravo. Krisada.
Hi, greeting from Bangkok. I is very pleased to be the moderator in this interesting session. Is the importance of the neck in the facial rejuvenating surgeries by the famous plastic surgeon from Spain, Dr. Francisco Bravo. Dr. Francisco Bravo, a Madrid-based plastic surgeon. He's trained across the major cities, including Madrid, Barcelona, Paris, London, New York, and Rome. He's completing the clinical microsurgery fellowship at NYU, and formerly, he is the program director of the plastic surgery at Dokuda Ox University Hospital and associated professor at Complutense University. Now he runs his own clinic in Madrid, and he also got award-winning speaker and published in the top journals. He specialized on the facials, eyelid, and body contouring surgeries. And he was the past president of the Spanish Association of the Aesthetic Plastic Surgery. And he served as the editorial board in the leading aesthetic surgery journals. And today, the topics it be the importance of the neck. You know that everybody focus for the rejuvenation on only the face, and the neck is to be the forgotten part. Dr. Bravo will explore for the anatomical correlations, the advanced surgical approach, and strategy to achieve the natural harmony of the facial and the aesthetic surgery. And thank you very much. And may I have Dr. Bravo, please? Thank you.
Maybe before that, sorry, Bravo. I think we give Steve a short a short introduction, Steve.
Yes, thank you for coming, Francisco. We're very excited to have you in Bangkok in January at the FATS meeting. I think you bring a refinement in plastic surgery that very few have accomplished over the years. Your work in the neck is stunning and beautiful, and as elegant as you are, your work is even more elegant. So I think I'm so excited for you to be introduced to the Asian audience. And without further ado, please let's have Francisco do his talk.
Thank you so much. Thank you so much for this kind introduction, Steve, Eddie, and Cruzada. Really, really, it is my pleasure to be with you today, and I am so excited to have the opportunity to be part of FATS, which is an incredible program that you've all put together in Bangkok. So I really look forward to that. I'm going to start my presentation that is going to cover mainly the neck, because oftentimes the neck is often disregarded. A lot of patients are oftentimes focused on the neck, and even some surgeons really focused on the neck, on the face, and really the neck has really a large importance about what we do. I have no disclosures for my presentation. This is not really a disclosure. I am a section editor for facial surgery of the American Aesthetic Surgery Journal, and if I have a chance to speak to an audience that really is very active and very innovative in the field, I really always want to encourage them to send their work to ASJ. You all know this is the most important journal to showcase your work. It has an impact factor of 3.9, even larger now than PRS. And of course, it's only focused on aesthetic surgery. So we have a lot of contributions from Asian authors. So I really do encourage you to send your work to ASJ. So I want to start off with this interesting work by our colleague from Turkey, Reha Yavuzur. He was the past president of the Turkish Aesthetic Society. He wrote an interesting paper where he showed what was the area of the female face that bothered them the most as they age. So when they are younger, initially in their 20s, it's their nose that bothers them. In their 30s, it's their nose that bothers them the most. Around their 40s, it's the periorbital region. But from their 50s onwards, the jawline is the area that they're more concerned about. So let's take a look at the jawline. I'd like to always think as an artist would portray beauty and youthfulness. And I'm sure that I know that many of us in the field of plastic surgery have a big interest in art. I know that Dr. Steve Cohen does, and he's an incredible artist. So when I look at an image of a drawing portraying beauty and attractiveness, anyone that has any training in drawing or art would know that this is not the way that an artist would portray beauty. They would do this. And that little change, that if you notice what happened there, it's this area here, what I like to call the extended submental line. This makes a big difference in really defining and describing beauty and youthfulness, right? So when you see an artist like this, a photographer who are also artists because they play with light and shadow, in this case, this photographer really wanted to showcase the beauty and the youthfulness of these models by doing this lighting that really showcases that extended submental line and that shadow along the full length of the jawline. So when I try to portray this in a model like this, you might think that, in order to do this, I just drew a shadow there underneath the jawline. Well, I did not do that. I actually took this model, a 3D model, into a 3D program, in this case Cinema 4D, and I put two lights, a spotlight and a disc light. And that way I can see how that light reflects on my model in real 3D. And now you have other programs like Marmoset Toolbox that really allows you to do this lights and shadow in real time with real-time rendering. And this is so valuable for us as plastic surgeons because we can, modify different parts of our models before the surgery and notice how that will change with the lighting and shadows. And of course, again, I want to really emphasize the importance of lights and shadows for artists. My compatriot Francisco Goya from Spain, he used to say that there's only light and shadow, and the greatest artist of all time, Leonardo da Vinci, said that forms of bodies could not be understood in detail but for shadow. And of course, we all know that he was obsessed with shadows, and at one time of his life, he really was really trying to understand how shadows are formed. So again, when you see this and you see that shadow, you have to understand that that is formed by the different angles between the face and the neck. So the most well-known angle is the submental cervical angle, which is around 100 degrees. And if you improve that, you will get an improvement on the jawline. Basically, you can do that with just a chin implant and a little liposuction underneath the chin. And of course, that is going to look better. So, this is better than not having that improvement. But, the real game changer is when you not only have this, but you go from that to having this. Now, that is jawline definition. And that does not come just from doing a little work in the submental region, but more on the lateral and posterior angles. And you can only see those angles from a view that comes oblique from the posterior or the anterior views in order to see that lateral submandibular cervical angle, right? So again, these are the views where you can see directly those angles. And this is an on-table result. You can see I modified that lateral submandibular cervical angle, and that's a posterior cranial three-quarter view. When I see that patient in the profile view, I will only see the submental cervical angle, but laterally, what I see is a shadow. This is the same lighting coming from above and the right side. There's no shadow here because there's no separation between the face and the neck. Here, I've achieved that depth underneath the mandible, and I have now my shadow, which really is what gives jawline definition. So again, my objectives when I'm doing a face and neck lift is to really have that nice shadow along the full length of the mandible. And I do that by addressing and changing the lateral submandibular cervical angle. I published my first series of gland reduction in facial rejuvenation in 2013. This was the first series on gland reduction in facelift surgery. The first gland reduction that was published was actually published by a Brazilian, Dr. Pina, in the early 90s. But Bruce Connell and Timothy Martin, Joel Feldman were doing this routinely around the early, mid 90s, early 2000s for sure. And then Brian Mendelsohn published his series of 100 patients later on in PRS as well. But I described most of the technique in this other publication in 2018. Oh, sorry, this was a publication on PRS in 2013, and this is my paper from 2018 where I described my technique of reduction neck lift. Basically, what I did here was propose an algorithm of maximal reduction, separating the submental region or submandibular region in 3 zones, and describing what structures needed to be reduced in order to get maximal reduction in that region. But thinking back, and I think we should all do that exercise on what our most important contributions to our field are. I think my important contribution from that publication was describing the lateral and posterior submandibular cervical angles, because up to that point, the only angle described in the neck was the submental cervical angle described by Richard Ellenbogen in his landmark paper from 1980 PRS. And again, those other angles are very, very important in order to provide a jawline definition. So what is my approach to doing my technique around the neck? I have 2 objectives, 2 goals when I'm doing a neck lift. I call it a dual plane reduction neck lift because one of my goals is to do deep work with volume contouring, and the other, of course, objective is to do a good superficial work with skin muscle redraping. And it's very important that these 2 objectives be separated, okay? Because oftentimes you see too many times surgeons, this is from a video I grabbed on YouTube, where a surgeon is pulling on the skin and is noting that he's having an effect on that neck, which is so far away from where he's pulling on, and noting that there's an effect on the neck. Well, we all know that that is sort of like trying to, tighten the superficial layers to avoid problems that are really originated from deep. And of course, we know that does not work long term. So the first one to really showcase this was actually Fuad Nahai with his paper in 2004 entitled Reconsidering Neck Suspension Sutures. And, he mentioned really that over operating in the superficial planes to improve on deeper problems did not produce long-lasting results. So he would say, initially there was some result, but then long-term, that result does not stay long-term. And you might think that, already after a person like Fuad Nahai, which is such a leader of our specialty, all the way 20 years ago, that would be sort of the end of the story. Everybody would sort of understand that you cannot push deeper problems with, pulling on superficial layers. I was asked to review this paper by UCLA, my good friend Jason Rustanian, who's an outstanding plastic surgeon in Los Angeles. But they were discussing whether gland was either more growth or was it more ptosis with a imaging study. And of course, that discussion was brought up because, at one stage there was some authors saying that you could pull on a platysma to really push that deeper structure into the floor of the mouth. And of course, we all know that that does not stay long term. So of course, you could get a result that will last maybe 3, 4, maybe 5 months. And if you grab a picture of the patient like that, you'll look like, wow, you didn't need to do any deep neck work. But of course, we all know that around 7, 8 months, all of that volume will recur because, of course, there's a lot of volume and it cannot withstand all of the flexion of the neck that happens over time. So I like to call that dynamic anatomy of the neck. So what happens with neck flexion? Of course, the neck is one of the most mobile structures in the body, or most mobile joints in the body, because it has actually 8 joints, right, with 7 vertebrae. So again, when you remove the skin and the muscle from a cadaver like this, you will note that all of that gland will sort of bulge out with flexion and move downwards. Look how downwards it moves, right? And when you remove the gland, you notice that the anterior belly of the digastric muscle also bulges down considerably. And you might say, okay, Francisco, this is cheating. When you remove the skin and the platysma of a cadaver, everything is going to bulge out. And of course, you are right to say that. It's true. So I decided to take my study in a live individual and a person with a thick and heavy neck like this. What I did is a lateral CT scan of that patient, and notice how most of that volume in the lateral portions of the neck are occupied the submandibular gland. We know from several anatomical studies that there's no clinically relevant fat compartments on the lateral neck. So when you do that, you can see that most of the volume is the gland. And then I went a little bit further. I did a study called a dynamic real-time MRI. These studies are done by orthopedic and neurosurgeons to understand luxation of the discs of the vertebra that sometimes happens in a specific movement of the neck, and they go unnoticed or undiagnosed with a normal MRI. So this is a dynamic real-time MRI to really show how much shift downwards there is of that gland when patient flexes their neck. So if you notice here, this is the submandibular gland right there. This is the level of the mandible. Notice what happens when a patient flexes their neck. Look how far down that gland is moving, all the way down to the cricoid region. And it's really difficult to think that with a flimsy muscle, there's the platysma muscle like that, you're going to be able to push all of that volume into the floor of the mouth where there is no space. It's the tongue. There's really no place to move that upwards, right? So again, this is what's happening in a little animation I did. Everything is being pushed downwards with a flexed neck. And again, we need to understand the surface aesthetics of the attractive flexed neck. Okay, so again, extended submental line, that nice shadow underneath the full length of the mandible. But again, with the flexed neck, you have to have a single creased neck, not a double creased neck if the patient is attractive and young. And I had a nice discussion with a very good friend of mine and a leader also of our field, our colleague, Dr. Mario Pellicerabolo. And he came up with a concept of a C neck and a V neck. And he mentioned that you can have a young individual that is attractive and young, and he or she doesn't have to have a V neck or a very sharp neck, sort of like a supermodel. They can have a nice soft contour and still have beautiful and attractive and young looking necks. And I totally agree with him. You know, that is true. The only issue is that when an attractive and young individual flexes their neck, they will convert, even if they are a C neck, they will always convert into a V neck. Okay, and they will always have a single crease neck if they are attractive and young. So when you try to imitate, you know, a nice soft contour, but not doing deep neck work on a patient like this that had an excellent, you know, face and neck lift surgery by one of the best plastic surgeons in our field that does not do deep neck work. They might look very natural in the static view, but when they flex their neck, I'm sorry, that is a double crease neck deformity. And that is a giveaway that this patient had surgery because that is not natural. It's sort of like a inverted V deformity or an alar notching or a polybeak deformity in rhinoplasty. It just happens if you don't do specific steps or maneuvers when you're doing surgery. And I like to show this because this is sort of called the Bible for artists for drawing and painting drapery. It's called the Hogarth book. And you see here, it's called bend wrinkles. Bend wrinkles are those that are formed in joints when one flexes a joint. So if you look, for example, at your hand and you look at your joints there, you will notice that the PIP joint is a double crease joint because it has a lot of volume going through it. There's two tendons going through that PIP joint. There's a very thick volar plate there, while the DIP joint is always a single crease joint because there's not much volume there. So we have to understand that superficial layers redrape differently if there's volume underneath or if there isn't, right? So what does my deep neck work consist of? Well, again, I have to notice that even in very thick, heavy necks like these, when you do a CT scan, most of that volume laterally is occupied by the submandibular gland. Look how thin that fat there is there. There's really no fat there. So you need to address that volume in order to get results on that lateral mandible. So my kind of workflow for my neck is, of course, addressing the deeper volume of the fat, the subplatysmal fat. I am conservative when removing subplatysmal fat. I will often leave a good amount of fat in the prehyoid area and also in the undersurface of the platysma to thicken it because it's a very flimsy layer to do application. In males, I might remove a little bit more fat because we know that the Adam's apple is a sexually dimorphic structure. So if you make a male look more masculine, you will make them look more attractive. But definitely in females, I will leave plenty of fat in the prehyoid area. Once you do that, you are committed to removing or reducing the submandibular gland. And again, I will do that in a staged fashion. And again, you can actually remove quite large specimens from the lateral region. And again, you can notice on my reductions here, this is the muscle, anterior belly of the digastrix, this is the gland, very little fat. Actually, this is a little bit of buccal fat pattern removed, very little fat from the neck, and most of the volume is from the gland and the anterior belly of the digastric muscles. So again, most of that volume is from the gland. And why doing that deep neck reduction? Of course, as I just mentioned, to enhance jawline definition and submandibular shadow, but also to avoid inadequate and natural results with neck flexion. This is very important. I just published this paper, just came out in June in ASJ. I'm talking more about zone 3, my zone 3, which is in the angle of the mandible with partial parotidectomy. As you can see here, some of the parotid gland I remove in some of my patients. And again, when you look at that structures there, you will notice that oftentimes I have, in that paper, I have readdressed the importance of the submandibular gland, even for zone 3. I initially described it in my 2018 paper as purely a zone 2 structure, but I have revised my classification and have divided zone 3 in a zone 3A and zone 3B. And actually, part of that posterior gland does have an impact on that zone 3A, that horizontal part of the angle of the mandible. And of course, that vertical part is occupied mainly by the tail of the parotid gland. So we need to talk about this tail of the submandibular gland, which, as you can see here in this little animation, that gland sort of embraces and hugs the mylohyoid muscle. Most surgeons will remove only the anterocaudal portion or segment of the gland. But of course, you can do that. You might leave a large stump, and you can actually tie that stump to the tendon of the digastrics, but then you have to make an incision that's quite low in order to approach that. Most of the times, I'd like to also remove the posterior cranial or posterior superior segment of the gland in order to get and impact that jawline definition all the way back to zone 3A. Okay, and again, if you don't reduce that part of the gland, you might end up with a visible stump, which actually can even mimic, paradoxically, an overdone look. Because if you leave that little stump there, you might have a big step off there, and it looks like a sharp kind of a step off there, and may look like unnatural or overdone, and actually you should have reduced a little bit more of that gland. So again, if you notice here, and this patient had an excellent facelift surgery done actually in the US, but they did not address the deeper structures on her. So she might look very good in the before and after. You might say, Francisco, why did you do again a neck lift on this patient? She didn't look much different. Notice what happens as she flexed her neck. Look at that gland starting to bulge out and occupy that space on zone 3A that I've been able to improve here. And again, as she even flexes more, that redraping of that superficial layer is not adequate. It's not forming a single crease. It's more forming multiple creases because there's no separation between the face on the neck on that posterior mandible, while I have been able to achieve that there. And again, that redraping, which is so much different when you address those deeper structures. Anterior belly of the digastric muscle is the third step you have to do because, of course, when you reduce the subplatysmal fat and the gland, oftentimes that bulging anterior belly of the digastric is what you need left there, and you need to address it as well. A little walk through some indications. Of course, the thick, heavy, full obtuse neck. You need, in order to address these necks, get these sort of results to address that deeper structure. I remember going to a surgeon in the US, and he was not decided or not to remove or not the gland, and he asked me, listen, Francisco, should I remove the gland? You want to grab some gloves and palpate if you need to remove it? And I said, no, I don't need to grab any gloves. I'm seeing the gland right now through the skin. And if you train your eye, you're going to be able to see that bulge like right here. And right here, you see that's the gland there. And that improvement of that extended submental line when you address that and your flex position of the neck. And again, that anterocaudal three-quarter view, that also improves so much with that deep neck work. Patients like these, really you need to address these deeper structures to get these sort of results, because if not, you will not be able to get this sort of definition and this improvement all the way down here without addressing the deep work. Male patients, I think, are an important group. You know, I wrote this paper in 2022 about neck contouring on male patients. Most of these concepts also apply to females, although of course male patients have more of a perifacial expansion as they age, and of course you need to give them that nice Adam's apple and provide those results in the canal flex view. Oftentimes you can do that only from a submental approach. I notice my limit is around 55 years old. This patient only had a submental approach, no skin from or no approach from the ear or behind the ear. And you can get away because we know in males we have thicker skin from the hair follicles. Females, I would not attempt a submental approach only on anyone older than 35 or late 30s. And again, some of these male patients, you can really improve that, again, that lateral submandibular angle, give them a nice Adam's apple, a nice flex view with that nice shadow all along the mandible. And again, notice that improvement on that lateral submandibular cervical angle. Again, these patients normally in the early 50s, they really take good care of themselves. They're fit, but they're not getting results around their neck. They have that laxity that they hate, and of course you can provide that to them with that deep neck approach. Young patients oftentimes are patients that are not considered for deep neck work because they're often proposed to do just a little liposuction. But you will, I often prefer to do a little short incision there in these very young patients in their 20s, because you can get that really nice, muscular mandibular triangle shadow there with the really showing that anterior sternocleidomastoid muscle line, which is very attractive in these, very young individuals, even in their early 20s. Instead of some have been proposed to do a chin implant. There's no problem with their chin most of the time. It's just going the other way in the submental region, and you can really get that result just by a little incision in the submental region. Again, patients in their 30s, and again, you might see here, there's really no problem with her angle there. She already has a right angle in the canal view, and you might say, why do deep neck work? Well, because you're going to get an improvement. Look at that nice shadow underneath that full length of the mandible by addressing that volume there. Okay, this is my youngest patient, a 19-year-old that was also proposed a chin implant, and I just went the other way with that teenager. Deflated thin necks, this is a very important group because oftentimes they're just told that they just need to get their superficial layers pulled up on. But of course, I always also want to understand what's going on with their deep structures, and I will reduce those deep structures in order to provide them a more appropriate look. And it's a very long-standing result. This is, again, a patient with very thin skin, but I did reduce that structure there, which is the submandibular gland. And this is 2 years post-op. This is 7 years post-op. I normally tell my patients that I do not need to address the neck once it's adequately taken care of. Another patient, you might see very thin skin. You might say, oh, only pull on the skin. I do reduce that structure there because that skin will not redrape the same way if I do not address that skin. So for my superficial work in my last 5 minutes, I'll have more time in Bangkok to go over this part because it's also important. But I just wanted to address the last 5 minutes to talk a little bit about this. Again, most of my superficial work I talked about in my dual plane technique from 2022. These are all the maneuvers I do for my superficial work, which is aimed at managing platysma bands and minimize recurrence of those bands. Of course, we do reduce deep work, and you might say, why does that have to do with superficial work? Because the work I do on my deeper structure improves the contour and the effectiveness of my platysma plication. Of course, if I reduce all that volume, that's going to be, having that so much pressure on my plication when my patients flex their neck. Imagine 100 times or more with patients flexing their neck. That's just going to make my platysma plication fail. And that's why it's so important to do deep work, because it affects your superficial work. And I do what I call the 3D Z-plasty, platysmoplasty, because I think this is the best way to avoid recurrence of bands. We know that from reconstructive surgery, when you have a band on the skin, the best way to geometrically separate those edges of the skin is by doing a Z-plasty, because that's the best way to physically separate it from each other the most. So what I do is I transect the platysma, I bring the cranial edge medially, and I bring the caudal edge laterally. And in this way, I have 3D Z-plasty configuration in the 3 axes of space, the Z, the X, and the Y. Let me just show you again how this looks. And again, when you have a band that looks like this, on that edge, the best way to physically avoid that from happening again is to just break the band and bring part of it on one location and the other part on the most opposing part possible. Then I do what I call the triple vector cranial platysma plication. For my plication on the platysma, medially, I will use 2 vectors. I will use a horizontal vector and suture that to the prehyoid fascia, remove the excess platysma, and then I will use an anterior vertical vector pushing the platysma anteriorly, and then of course I will have a dog ear on my platysma, and I just remove that dog ear with an inverted T or a Burroughs triangle resection. And that way I get a very nice flat surface on my subplatysmal segment. And then from lateral, I will use my 3rd vector, which will be a plication laterally on my cranial platysma. So this is a very effective way of removing very complex platysma bands that she already had an attempt by another surgeon to improve them. Patients with very thick platysma muscles, and you can see long-term that improvement of that platysma muscle with no recurrence of that platysma band. Very heavy muscle bands, and no recurrence long-term with that 3D Z-plasty platysmoplasty. Finally, I do what I call the caudal cervical thick composite subfascial flap. I published this in my dual plane neck lift paper from 2022 because I will keep that skin and attach it to the platysma, and I will even go deeper than the platysma and go underneath the deep cervical fascia. So this was first described by Skoog in the 60s. He was, pulling on the platysma, and that helped him as a carrier for the skin. That was forgotten, and then Raul Gonzalez from Brazil brought it up again in the early 2010s. And then Mario Pellicciarabolo popularized it with his LSD technique, lateral skin platysma displacement. My concept is different than that because I go underneath the deep cervical fascia and I will undermine and release all the retained ligaments of the platysma and that deep cervical fascia. And now it's been called or sort of baptized as a preservation neck lift. But again, I think that my paper from 22 really comprised that sort of benefit of leaving that skin platysma attached, which was again first initially proposed by Tord Skoog in the 60s and popularized by Raul Gonzalez and Mario Pellicciarabolo. So this is my dual plane. Again, 2 planes here. This is all left attached, and this is my point of transection of the platysma. And that way you can handle these patients with very thin skin where you do not want to release that skin from the platysma. You want to leave that attached and just go and use your deeper layers, a deep neck lift, deep plane neck lift, actually, not only deep neck work, but also that plane of dissection very deep. This is 3 years post-op, and that was the way that you can improve on that skin without having any problems. And finally, my caudal platysma weakening, which is trying to injure the second branch or the caudal branch of the cervical branch of the facial nerve while leaving the cranial branch intact, because that cranial platysma is a depressor of the lower lip. I published this in my paper with Leonard Minelli and the Australian group in 2023. But again, you can weaken that platysma and improve those horizontal wrinkle lines on the neck that are dynamic wrinkles by doing that technique. I will also did a lip lift, which I hope to talk about in Bangkok. It's a powerful technique. And again, notice that improvement on that skin without any skin treatment at all, just by doing that weakening of the caudal platysma. And again, the patient would look, those wrinkles there, look at those wrinkles on the skin, no skin work, just that, releasing and transection of that caudal branch. So to finalize, I think that it was shown by this great discussion paper by James Stewson that, due to the success of injectable fillers and neuromodulators and different techniques that are non-invasive in the face, most of the patients that seek the work of a plastic surgeon really want improvement around the neck. And I like this quote by Mark Twain where he said, history doesn't repeat itself, but it sure does rhyme, because all the way back in the 1970s, an individual called Jose Guerrero Santos, who was one of the really pioneers of our specialty, together with Pitargui from Brazil, Guerrero Santos from Mexico, already said, that patients that want to have a facelift worry more about the changes in the neck, and any surgeon performing facelift should use all their ingenuity and skill to obtain optimum results in the neck. So that's why, I had the opportunity to see Joel Feldman in the early 2000s, and he wrote this book called The Neck Lift, and at that time he was doing deep plane facelifts as well. And I always was waiting till he published the second volume that I was hoping that it would be called, Facelift, to accompany his volume of neck lift. He never wrote it. Why? Because, it didn't matter, the face, I think really in facial rejuvenation surgery, the face is overrated. Of course, when we're talking about surgery, maybe around the face, the lip lift is very powerful, eyelid surgery, brow lifting is very powerful. But I think around the face, the most important part is the skin, and really rejuvenating, regenerating the skin, which is a field that, you know, our host Steve Cohen is such a pioneer and leading the way on what we're doing on the skin. These are just resurfacing with cotton oil peels, but definitely all the regenerative part of it is really incredible. The results that can be achieved with stem cell research and all the work that is being pioneered by none other than Steve Cohen. So again, I think that the neck lift is the new facelift in terms of surgery. I really invite you to all to come to this incredible meeting. I've seen the program; it is outstanding. Really, congratulations to all the organizers, to Eddie and all the people, Dr. Quezada as well, and all the persons involved in this. Steve Cohen, thank you so much for having me in this incredible meeting, and I really, really look forward to seeing you all in Bangkok. Thank you very much.
Thank you, Bravo. Thank you very much for the presentation. Now we are open up the floor for questions. You can put your questions in the chat or in the Q&A. So, Quezada, you want to take the questions?
Yes. Thank you very much, Dr. Bravo, for the terrific and very interesting topics. There are a lot of informative data from your presentations, and I can't wait to see your cadaver demonstration in Bangkok for the next year. I have some couple questions from the floor that you said about the submandibular gland resection and the partial of the tail of the parotid resection. How many percent that you do the submandibular gland and also the parotid gland resections?
That's a great question, and I will never say 100% because you can never say every time, but I will say that most of the times that I will go into a facial rejuvenation surgery, I will do deep neck work more than 95% of the time, because it's sort of like when you're doing a rhinoplasty for a large nose, and you're trying to reduce a large nose. Most of the times you're going to end up doing some work on the dorsum, right? So maybe some patients have a larger dorsum, some patients have a smaller dorsum, but of course in the Western nose, most rhinoplasty will involve some work around the dorsum. So I see it the same way. You know, some patients have very large glands, and of course they need that. But other patients, I might just do a little contouring of that structure because I want it, you know, really that neck to look good in the flex position. And I might end up just taking a look and reducing a bit of it as well. Yeah.
Yes. Okay. And after you do, I think this year also have some review of the complication of aesthetic submandibular gland resections, about the xerostomia, about the hematoma and cellulose. Do you have any complication in your and how to prevent or manage with the complication with the
No,
submandibular resection?
that's a great point, Dr. Quezada, and it's a very important point. So there are 4 complications that can happen with the submandibular gland reduction, okay? 2 of them are hyper-emphasized and they're not really that relevant clinically. 2 of them are real and can happen. So the 2 that are overemphasized are 1, nerve injury. Okay, so there's about, and you look at the literature of gland resection, there's about a 5% permanent injury to the marginal mandibular branch. This is from oncologic literature where they're reducing a tumor in the gland by going directly over the gland. Of course, if you go directly over the gland, you're going to have to go through the platysma, through the deep cervical fascia, where that marginal mandibular branch and the first branch of the cervical branch of the facial nerve go, and you can injure that branch. If you go from anteriorly and leave the capsule, which is where the nerve is running, and use low power settings, it's very difficult to injure that facial nerve. If you go from a lateral approach to remove the gland, like for example Mario Pellettiravolo does, he will have, and he's confessed that he has a higher incidence of lower lip weakness because he goes from the lateral approach. And of course, when you go from the lateral approach, have to go through that deep cervical fascia to access the gland, and you might injure some of those nerve branches. But I think that going from the anterior approach and leaving that nerve above, you're not going to injure the nerve. The second problem that has been overemphasized is serostomia or dry mouth. Okay, this is because most of that gland resection is from the oncologic literature, because that's one of the maneuvers you need to do when you have cancer or oral cancer. You need to you do a lymph node resection with a gland resection, and of course all of those patients have dry mouth afterwards because they all receive radiotherapy. I think it's very rare to have dry mouth. There's an over production of saliva from the remaining stump of the submandibular gland. And I think that if you leave enough of that gland behind, you shouldn't have problems with dry mouth. The two problems that are real, one is sialocele, as you mentioned, Dr. Quesada. I have around 2% of sialocele. Normally, the thing that I see that has the biggest impact on reducing that is having a salivary rest diet. So patients cannot chew for the first 10 days after surgery. No biting, no gum chewing, no steak, no salty foods or spicy foods or sour foods or citric drinks, no alcohol. That really has rest on the salivary. I also put anticholinergic drugs like buscapine in order to reduce saliva production. But then there's the other, that is the biggest problem with gland reduction, which is very profuse and difficult to control bleeding intraoperatively or in the early postoperative period. That's why this is a true problem. I've heard from my presentations, all around the world with some very, very severe life-threatening complications by some younger, bold surgeons who have this sort of peak of overconfidence, thinking that, they can manage this surgery because it's very easy, and then they run into very difficult problems to solve in the OR, or having a patient being trached in the postoperative period with a very expansive hematoma in the neck. So that is why I really encourage you all to first take cadaver workshops. That's why your meeting is so important that you're doing there in Bangkok, because you need to be walked through and see those little perforators, see how close they're coming off of that facial artery and submental artery, and go visit surgeons that are doing these techniques. Because again, I think we need to be aware of this problem and really handle this very carefully.
Yes, thank you very much for very clear questions. And move to the next question from the participants. They ask that, does you do the submandibular gland resection with the central approach, or you need to do lateral approach, or the central can doing well with the submandibular gland resections?
Well, that's a good question. So I'm comfortable doing the submental approach from a very high incision. This is complex to do technically, especially when you remove that posterior cranial segment. It's very far away. So I would advise surgeons that have less experience to either place a lower incision initially. I don't like it because it's more visible, but if you talk with your patients, they might accept a lower incision, that it's easier to manage because you can make it longer. Up here, you have to make it very short because when you do the facelift, that scar can go into your face. So it's harder to do it from here. From the lateral approach, the problem you have is that you often have the common facial vein and the facial artery covering that posterior segment of the artery. So some surgeons that are doing it that way are just ligating the facial artery, which I don't like to do, and ligating the facial vein completely. Again, I don't like to do that. But you have an easier access if you don't mind sort of having a higher percentage of lower lip weakness postoperatively. I would recommend the anterior approach.
Yes, thank you. And the next one is my old questions. When you select for the only submental approach only, or how you select for the only anterior approach, or you do both anterior and lateral approach in different patients? How
Yeah,
to select?
That's a great question, Dr. Quesada, and a very difficult one to answer because again, there is sort of a gray zone where you will not have a good result if you just do a segmental approach. So my experience is in males around early 50, early 50s, if they really don't want a lateral push, but they need to have quite a larger beard. If they don't have hair in their beard, it's a totally different scenario. In females that don't have hair, or males with very little hair in their face, I would not do an anterior only approach in anyone past their late 30s. I am doing a combined approach, which is a segmental approach only and a posterior retroauricular approach only. So in some patients, I can extend that age and do patients in their mid and late 50s by just doing or females in their early 40s by doing just a posterior approach and being able to grab that caudal platysma and bring everything laterally without affecting the face, because oftentimes they don't have issues around the face. And you can get a good result around an isolated neck lift by just doing that lateral only retroauricular incision and segmental incision.
Yeah, this is great technique and great tip for for us. Move to the next questions from the participants. They're asking that do even use the Botox, I mean the toxin after the surgery, and if you do that, how many units that you do for that?
That's a great question again, Dr. Usada. I used to do that intraoperatively. I would place a little Botox around 15 units on each gland on the stump. And I stopped doing that after a patient that I saw. Of course, I see them when they wake up, and the next morning they were moving their lip perfectly. And at 3 days, when they came to have the net removed, they couldn't move the lower lip at all. So that Botox must have diffused to some of the musculature around the lower lip. And after it kicked in, after 3 days, the Botox kicked in and they could not move part of their lips. So I've also heard of colleagues directly telling me that some of that Botox has diffused to the muscles involved in swallowing, and they've had to have their patients with a nasogastric tube for even a month after the surgery, which is terrible for a patient in aesthetic surgery. So again, I tend not to do it. I know that now maybe with ultrasound guidance, some surgeons are doing it to managing a sialocele. I will do it in the parotid region if they have a fistula or a sialocele in the parotid region, which is more rare. But I will inject Botox in the office afterwards if they have that problem, because there's no problem. I mean, they have a little masseter kind of atrophy for a few months, but then it will recover, of course. But that's a good point. Some surgeons really like to do it, but I'm tending not to do it.
Yes, thank you so much.
Okay.
Dr. Cohen, you have raised your hand and you
Yeah.
have to comment any word. Yes, please.
Yes, Francisco, I have two questions. The first is, when you're dealing with the parotid tail area, what are you doing technically? That's my first question.
Right. So what I'm doing there, depending on the size of the tail of the parotid gland, I'm either identifying the main trunk of the facial nerve and just following it anterogradely, and removing a large portion of the tail of the parotid gland and even the superficial lobe of the parotid gland. But most of the times I do what I call a type 1 resection. I published this classification in clinics, and then again, this is what my last paper talks about: this partial reduction, which is the technique I do the most. I just elevate the parotid fascia, and I remove just a small. As long as you stay in the behind the ramus of the mandible. The facial nerve runs very deep at that level, as you know, Stephen. It runs like maybe 2 centimeters deep. So as long as just remove exactly a portion of that tail of the parotid gland and taper it very well as you approach the edge of that tail of the parotid gland, you're not going to injure the main trunk of the facial nerve or the inferior division of the facial nerve, as long as you stay within the confinement of the parotid gland. So that's what I do in patients that have large tail of the parotid glands, which come up to be around maybe 15, 18% of males and around 7-10% of females. Most of the time in that area, I do what I call the triple plication for zone 3. So I do not undermine, like most surgeons do, where they're doing a full unit between their deep plane and the neck. They're just elevating that facial platysma together with the cervical platysma. I'm not doing that. I'm elevating my facial platysma with my deep plane facial dissection, but then in this area of the platysma, I'm just doing a plication of that cranial platysma here. I go underneath the platysma from anteriorly, but from lateral here, I only elevate it caudally. I do a transection of the platysma, I tuck this area inwards here, and I elevate the cervical, the caudal platysma upwards. So this is the biggest danger zone for that first branch of the cervical branch of the facial nerve, and I do not go underneath the platysma right there. I just do a plication there, I tuck it in there, and although some surgeons say that, if you transect the platysma, you're not having an effect of your deep plane on the face on your neck, well, I have plenty of effect on my neck from my neck work and my, elevating my cervical platysma and freeing all of the retaining ligaments of the platysma on the neck. And I have plenty of work on my facial work, just from my deep plane face work. So I don't like this approach of thinking of, working on your neck from elevating tissues on the face. I know that it's a little bit counterintuitive, because a lot of surgeons think like scientists and less like artists. They're thinking, okay, what is the etiology of aging? And it's like descent. So you have things that were before on your face and they fall on your neck with your jowls. And then the correct treatment as a doctor, where you're thinking of treating etiologically, what is the cause, is just bringing that back where it belongs. Well, I don't think if you have an artist and they're shown a sculpture of an old face, they would not bring that clay up into the face. They would just remove that clay and just sculpt the beautiful face. So if I see volume here around the neck, I don't bring it into the face. I don't pull on my facial platysma to bring anything on the neck into the face. I do my neck work and then I do my face work. Yeah.
And my second question, Francisco, is, and maybe I have this wrong, with your Z-plasty, are you addressing just one side at a time with those Z-plasties?
Exactly.
So, why not do it like a furlough?
Right. That is a very, very good point, Steve, and that's why I love being in these discussions with surgeons that really, like all of you, that understand these nuances of the technique. So that's a very good point, because you're right. A true platysmoplasty, a true Z-plasty, is not only based on the concept of a Z-plasty, which is geometrically separating the edges of a band as far away from each other. That is the concept. But the way a Z-plasty also works is not only that, but by interposing tissue between those Z's, right? So you mentioned a furlough technique, or even like Guerrero Santos used to have a Z-plasty technique for the neck, where they would interpose those Z's on the neck from the contralateral platysma. So my concept is different. I call it also a Z-plasty because I keep that concept of dividing my band into two segments, and I separate geometrically that band from each other as far away as possible, but I do not interpose tissue between those two structures. So you're totally right. A true by-the-book Z-plasty has those two components. It will separate the bands as far as possible and interpose tissue so that you avoid recurrence. But I do each of my platysma work independently from each other, because I do a very strong plication. I will not rely on my plication from one edge of the platysma to each other. I will really fix that platysma edge to the prehyoid fascia. I'm sure that I'm having that vertical segment of the band hold there, and then I'm pulling that caudal segment of the band to the contralateral side with a very strong suspension of the whole neck laterally. So that is a very, very good point, Steve. Very good point.
No, I was just curious. No, well,
It's very
thank you.
good.
No, and beautiful work, Francisco. And you're right. We're at the intersection of science and art, and I guess really psychology.
You're right. That's true. That is true. Thank you so much. Thank you.
Thank you, Dr. Cohen. And we also have some questions from the two of the participants, and the organizing let them ask you directly. So please unmute your phone and maybe introduce yourselves and ask directly to Dr. Francisco Bravo. Please, Lush, the first is Dr. Lush. You raise your hand and you can unmute and ask directly. Or Dr. Lin T, you can unmute yourself and ask directly with Dr. Bravo. Hello? Yep. Okay, I think I don't know what happened, but it's okay. So I think it's maybe uh very interesting, and you have told us about how to management strategy for the young people, the old people, for the males and the females, and for the thin skin, thick skin, the only submental approach or the lateral combined approach. So Dr. Lash, do you want to talk any? No? Okay. So we will move to the closings by Dr. Steve Cohen to please comment for our closings, please.
Yes, I want to say thank you again, Francisco. And we're very much looking forward to seeing everybody in Bangkok at the January 16th to 18th next year. So please come and visit us. You're going to have a fantastic meeting. And again, Francisco, have a wonderful day or eve. I guess what time is it over there? It's a little bit in the afternoon
It's
still.
4 p.m. 4 p.m.
4
already here.
p.m.
Yeah.
Yeah. So have a nice
It-
evening, a nice dinner.
Thank
Sometime
you so much.
tonight, I'm sure at 10 o'clock you'll be
That's
eating.
right. It's siesta time now. It's siesta time.
Spanish
Yeah.
style, yes. Very
Exactly. Yeah.
nice. Good to see you guys. Thank you.
Okay. Thank you so much. Thank you so much for this opportunity to share with you some of my work. And I'm really, really excited to be with all of you in Bangkok. It's going to be an outstanding meeting, and I really look forward to it. Thank you so much, Dr. Eddy, Dr. Krizada, and Dr. Cohen. Thank you. Thank you very much.
Take care.
Thank you.
Thank
Yes,
you,
also really welcome you all
Bravo.
to Bangkok. Yeah. Okay, Eddie,
Yeah.
let's go.
Thank you, Bravo. Thank you, Steve. Thank you, Kristada. Thank you very much. I'm so happy and honored to really work with you guys. Really looking forward to host it in Bangkok. Yep. Hmm. Okay.
Perfect.
Without further ado, we will close the session. Thank you very much, guys. Have a good evening
Okay.
and
Ciao,
Thank
good
ciao.
morning,
you.
please.
See you soon.
Bye.
Thank you.
Yep. Yep. For any doctors that's interested, you can register online. And yep, for the early bird. Thank you very much, guys. Thank you.
Bye.